Hello, everyone. This is Vicky from NP Reasoning. Today, I'm going to be diving into how to summarize a case succinctly and efficiently, and also how to document so you're not missing anything pertinent when you communicate the case to somebody else or within the patient's chart. So, without further ado, we're going to get into it. Really, we're going to help you gain confidence in presenting any case that you come across. So, first off, I think a nice way to kind of tease your case apart is by separating it into three categories. So you want to know, at the end of seeing that patient, what's the most likely cause for their symptoms? What are the less likely causes and how have you ruled them out? And what are the must not miss diagnoses that you thought about and that you've either ruled out or you are actively trying to rule out? So, with this case, let's say an older female presents with acute dyspnea. So, she's acutely short of breath. What I like to use is the systems framework to tease out what etiologies could be causing this shortness of breath. So, thinking about respiratory causes, cardiac causes, renal causes, and hematologic causes. These are the four main buckets that I'm going to use to guide my history, my physical exam, and any additional tests that I need to order. Again, helps you tailor it so you're not winging this presentation, and it helps prevent you missing, especially those must not miss diagnoses. So, when you see this patient, they tell you that they have fever, fatigue, cough, they're not coughing up blood, there's no leg swelling. You use the Wells score to risk stratify your pretest probability for DVT and PE. It's a low pretest probability. So there's no chest pain, there's no angioedema, no hives, no palpitations or syncope, no sweating. So with that, you're ruling out a lot of things, right? Less likely to be a pulmonary embolism, less likely to be acute coronary syndrome. There's no signs of anaphylaxis. So already you've more or less teased out those must not miss diagnoses. She has no past medical history, so a generally healthy person, but it is the flu season, so prevalence of viral pneumonias and things are higher this time of year. They do have a fever, slightly tachycardic, regular heart rate, respirates normal, and you do hear crackles in the left lower lobes. There's no pitting edema on exam. So, at the end of the day, with my history, my physical, and maybe additional tests you're ordering, depending on whether you're in an outpatient setting or the emergency department, you're thinking about what's the most likely diagnosis here? Probably pneumonia, based on the presentation, based on disease prevalence at this time of year, if it's flu season. There's mild tachycardia, there's crackles in the lobes, they have a fever. It's less likely going to be heart failure. Again, no risk factors for heart failure. There's no pitting edema or there's signs of heart failure. Kidney failure, again, less likely because there's no past medical history, no pitting edema. Again, less likely anemia with that presentation of fever and crackles and cough. Again, less likely arrhythmia. There's been no syncope, no palpitations, no history of heart disease. PE, you've used your Wells score to risk stratify that, and it's low. There's no risk factors for PE. There's no leg swelling to indicate a DVT. Acute coronary syndrome is less likely. There's no chest pain. In the emerge, you might be doing that workup just to make sure you're not missing it. And anaphylaxis, there's no signs, there's no history of allergic reaction. So, with a case like this, especially when there's major red flag diagnoses that I want to make sure I have documented, communicated with the patient, or communicated with colleagues that I might hand off with, I literally document it just like this with the rationale behind it. It also helps you reflect on the case to make sure that you're safe to send this person home and you're confident with that most likely diagnosis that you've made. So let's work through another case to illustrate this type of case presentation. Let's say a female patient's coming to you with pelvic pain. So again, I like to use the anatomic framework for many pain presentations. So thinking about, female anatomy, you're thinking of the genitourinary system. So gynecological system, I should say, ovarian pathology, uterine pathology, vaginal or valvular pathology, cervical. There could be a lot of things, right? Thinking about pregnancy, of course, Thinking about the abdominal area. So could it be, appendix, bowels? So again, just using that anatomic framework to guide my history and physical off the bat. So on history, pertinent positives, definitely that missed period. She's been spotting for a week. There's been no diarrhea, no fevers. She denies any high risk sexual activity and no significant gynae history like fibroids or endometriosis, etc. No surgical history. On exam, she is tender to that left lower quadrant with rebound tenderness. And with the pelvic exam, you're noticing a little bit of bleeding at the cervix. So, and if I were to have to tease this out in my documentation and in thinking through the case, I'd want to be thinking about, okay, what's the most likely diagnosis at this point? It could certainly be an ectopic pregnancy or a miscarriage, given that missed period with spotting and acute abdominal pain. So I'm not there yet. I'm going to need to order more testing, like a quantitative beta HCG and pelvic ultrasound, for example. Less likely infectious. I mean, there's no fevers, myalgias, low risk sexual activity, but you might be doing swabs, right, to rule out a cervicitis or a pelvic inflammatory disease because it's a must not miss diagnoses depending on the situation. Less likely endometriosis, fibroids, or GI related, again, with the history and the physical exam. And then again, those must not miss diagnoses. You're still going to have to work through that ectopic pregnancy possibility before you send this patient home. And possibly pelvic inflammatory disease needs to be on your radar because that's something that you wouldn't want to miss because people can get very sick with that type of diagnosis. Again, this is just a way that you can think about communicating your case, thinking through the case, and then documenting your case, especially with these more like acute concerning presentations that might come to you in an outpatient setting or the emergency department. So, key take home point here, you can certainly try using this most likely, less likely, and must not miss approach to summarize your case and for documentation purposes. Again, just helps you make sure that you've been comprehensive in your approach, you've documented everything, and you're not leaving any stones unturned. Thank you so much for listening to my talk here today. Again, all the content is on the NP Reasoning blog. Please feel free to check it out. Thank you so much, guys.